Hello, I'm Olga
Hi,
Dobrovolska from
hello.
Bookimed, and today I have a pleasure of speaking with Mr. Merimsky, an expert in oncology treatment in Israel. Our talk today is crucial as it will bring you insights and information about innovative cancer treatments directly from Israel. This knowledge is not just important for us, but vital for our patients and medical coordinators who are tirelessly working to find the best care. We are here to learn from Mr. Merimsky's experience and to share this understanding to help guide and support our patients through their treatment journey. Thank you for joining us in this important discussion. So, I'm going to ask you a few questions about your practice and about the cancer treatment. So, Mr. Merimsky, could you tell me, please, what are the special cancer treatments that you use that others doctors or clinics they don't? And what results do they show?
The most important thing in cancer treatment is cancer detection, early detection of the disease. Because if you detect the disease at an early phase or stage of the disease, then you have chance to cure it. If the disease is diagnosed in the metastatic stage, so the chance for cure is minimal. And the aim of the treatment is to get control of the disease and prolong survival. But usually there is no cure. The treatment nowadays is based mostly on a molecular analysis of the tumor. This is a new approach. This is the modern point of oncology. There are several modern points that we have to discuss. One is that the treatment is not good for everybody. The treatment is going to be according to the molecular analysis of the tumor. It is not enough to say that somebody has adenocarcinoma of the lung and he will get chemotherapy and that's it. We have to tailor the treatment according to the biological characteristics of the tumor. Means that the tumor sample is sent to a laboratory and the molecular analysis is done. And the aim of this analysis is to find specific mutations of the tumor or specific biological characteristics that can be used for better treatment. Now, if the treatment is more specific, so the results should be better. This is very important. It is a standard of care in, for example, non-small cell lung cancer. You cannot start treatment of non-small cell lung cancer without knowing the biological profile of the tumor. Some years ago, this analysis was used only in the setup of metastatic disease. You had to know the tumor biological characteristics to find the mutations. And if there are mutations, treat the mutation by targeted therapies or use anti-PD-L1 immunotherapy. And if you have no mutations and the PD-L1 is low, so the basic treatment is chemotherapy.
Mhm.
Then the analysis moved forward to the early stage of lung cancer, and now it is used in the adjuvant setup, is in the postoperative treatment. You don't start the postoperative treatment without knowing the EGFR or ALK mutations and the level of the PDL1. It is not enough just to give chemotherapy because chemotherapy gives a benefit of 5% in survival, and this is not enough. And patients with EGFR mutation or ALK mutation, they can get osimertinib or alectinib, respectively, for targeting the mutations and improving significantly the disease-free survival. Means that the control of the disease by those agents is much better than with chemotherapy alone. So when we use this approach, we have great success in the treatment. So this is one point of new thing. Another point is that every case, and I repeat, every case is going to be presented at a multidisciplinary tumor board, the MDT, and each case is discussed before we touch it, for the first time. The tumor board is based on discussion of the oncologist with the thoracic surgeon, with the pathologist, with radiologist, with the medical oncologist, radiation oncologist, all the team together decide how to approach the patient, and it is done individually. We have protocols, but we have to select the protocol according to the patient and the tumor characteristics. And this is done by the whole team. In the past, a patient came to the pulmonologist and then was referred to the oncologist, to the surgeon, one by one. And the decisions were made according to the referral, according to the physician who saw the patient. Now the decision is made by all the team together, and then we start the treatment. So this is very important.
It is so impressive to know that there are so many people involved in the treatment at one
Yes.
time as a team to have such a high success level. Thank you so much for sharing that. So, in terms of patients who were diagnosed with cancer, so can you name any three common errors in the cancer treatment approach that you have seen in the patients that started therapy in other countries?
Okay. So well, I see many mistakes. The first mistake is that the patient is referred to a surgeon. A patient with a big tumor is referred to a surgeon. And for this mistake, let's take the example of soft tissue sarcoma. The patient comes with a huge mass in the thigh. The mass can be resected, but the chance to get free margin is low. But the surgeon is a surgeon. He knows how to cut, and the surgeon thinks that he can do the job perfectly. Then the patient goes to surgery, and the margin are marginal or involved. So there is inadequate surgery, and then there is also a violation of the tumor bed because somebody has resected the tumor and left some tissue behind. Then there is wound healing, and after wound healing, the pathologist says that the margins are involved. So the surgeon goes back to the patient and do a second resection, and then the resection is not adequate in size, and the margin can be involved again or narrow and not enough. And then the patient is referred for radiation therapy. Radiation therapy, if the margins are involved, will never kill the tumor. Radiation therapy is not a compensation for inadequate surgery. And then during radiation therapy, when the disease is left in the thigh, the disease may start growing back. And there is local recurrence during the radiation therapy. And then the patient goes to the medical oncologist. And the medical oncologist now starts to try to get some strategy of how to get control of the disease. The point is that the first physician that the patient has to meet is the oncologist, because the oncologist is the case manager. And if the case manager is not involved from the beginning, so then there is a line of many mistakes that each step tries to compensate for the first step, to correct the mistake. And the patient finally comes to the medical oncologist with metastatic disease, mostly in the lungs, and he's doomed. He could have been cured by a by good strategy, and he's doomed because of mistakes. And when we use the tumor board and we decide what to do, yes, the tumor board is managed by the team, and the team decides how to proceed. And then by this way, we minimize the mistakes, and we try to avoid mistakes and to tailor the correct treatment for the patient. A patient with a huge mass in the thigh should start with preoperative chemotherapy, then preoperative radiation therapy, and then surgery, and then doesn't need anything else because the disease is out of the body. So this is the correct way to deal with the huge masses.
Thank you for sharing that. So it would be really important for the patients who were diagnosed with a cancer to find out the right way. So from where to start, not from the surgeon, but from the
Never from the
oncologist.
surgeon.
Okay, so if we talk about the patients who have made mistakes, yes, and they have already metastatic cancer, we are aware that you are really successful and you specialize on working with the patients with the metastatic cancer. So, what are the treatment methods that you use for to achieve a good result with those patients?
Well, first of all, I send tumor tissue for NGS. This is the next generation sequencing, or in slang, the molecular analysis or genetic analysis of the tumor, because I want to know the biological characteristics of the tumor that can help me to choose the correct chemotherapy, or to choose the targeted therapy in order to try to get control of the disease. Only then we start the treatment. In some cases, let's say with the metastatic lung cancer, you feel that you don't have time to wait the 3 weeks till you get the results of the molecular analysis, because the patient is coughing, he's breathless, he has a dyspnea, and he has a hemoptysis, he has blood in the sputum, and he has pain, and you have to run with the chemotherapy. So you send the tissue sample for the analysis, and you refer the patient to the day clinic or to the ward, oncology ward, to start the chemotherapy as soon as possible. Only then, when you get the results of the molecular analysis, you can update the way you choose, add something, delete something, or just give the patient some targeted therapies if there is a mutation.
Thank you so much. So, you also especially work with sarcomas, with such type of tumors. So, could you share with us which sarcoma types respond best to your treatment?
Well, it is not which type of sarcoma is responsive for treatment, because we have to give treatment to all the sarcomas. We cannot predict which which type or which sarcoma in an individual patient will respond to chemo or not. If there is an example of a nerve sheath tumor, that it is called malignant peripheral nerve sheath tumor, this is a sarcoma that originates in nerves, peripheral nerves. In some cases, the tumor is resistant to chemotherapy, but in some other cases, it can be very responsive. And I cannot tell you, I cannot predict from the beginning in which patient this tumor will respond or not. So I give chemotherapy for all the patients. It is true that several tumors are known to be responsive and others known to be chemoresistant. Even the chemoresistant tumors can be approached by treatment. It is very rare that we don't give a systemic treatment for metastatic sarcoma. Even in cases of chondrosarcoma, which is chemo-resistant, relatively chemo-resistant tumor, there is an option of giving chemotherapy. The only very problematic sarcoma is called chordoma. It is located in the spine, and this is a real problem because it is resistant to all types of chemotherapy. We have soft tissue sarcomas, we have bone sarcomas. Bone sarcomas are more responsive. Ewing sarcoma. We also treat spatial GI sarcoma. It is called the GIST, gastrointestinal stromal tumor, which is chemo resistant, but the important thing is that this tumor is very responsive to targeted therapies like imatinib, sunitinib, and there is a long line of drugs that can treat this tumor. And patients, if they come with a localized disease, they get adjuvant treatment, postoperative treatment, and they are cured. And if they come with metastatic disease, they are treated with targeted therapies, and we can get a very long control of the disease. So 5 years with metastatic GIST is where we see it almost every day. It is not rare. So there is chance. If there is metastatic GIST, there is chance for long survival. So patient has to have to know that they don't give up. Even with metastatic soft tissue sarcoma, metastatic bone sarcoma, Ewing sarcoma, they have to know that they should not give up. They should come for treatment.
So, as far as I understand, so patients' positive attitude and belief in recovery, it's very important for treatment success.
Yes, the patient should believe that there is a way, and even the, even if there is no recovery, there is a chance to prolong survival. Because the Israeli way of thinking is that we should not give up. There is first line, there is the second line. If the second line is not effective enough, there is third line. In Israel, we don't have the policy like in other countries that after first line, second line, you send the patient home to die. We try to prolong survival with the third line, fourth line, and more. Now, another very important point is that we have many clinical trials. Clinical trials is testing of the efficacy of a drug, of a new drug, on patients. It is supported by the pharmacy. It is conducted by pharmacy. The good point is that we can get new drugs that are not available in the market, and they give chance for the patients. And even if there is no effect in the first line, second line, etc., and the patient is willing to get into a clinical trial, and there is a clinical trial especially for him, so he can be enrolled and get a chance. So another point of clinical trial is the service. If the patient is on clinical trial in a public hospital, he gets a VIP service because the hospital is interested in the trial. So, so that's how and that's why the patient is being treated like a VIP. Now, there is it is not easy to be enrolled into a clinical trial if if you are not a citizen of a country, of a certain country. But there is an option sometimes to get drugs out of the protocol of the clinical trial and to try to give them as a regular service. So there is a way to try to overcome the limitation of citizenship. And this is important to know.
So basically, when the patient they get cancer diagnosis, so do you suggest them to start treatment at home or come to Israel right away?
Well, it depends. If the patient wants to get modern approach, modern treatment, he should come to Israel. Let's say if he meets me at the first moment, then I take the case to a tumor board in the hospital, or we conduct a limited tumor board, especially for this patient, because if we need a surgeon, in several cases we invite the surgeon to the clinic and we discuss the case together with the surgeon. We do the consultations, not all the team together, but the team part by part according to the need. But if there is a medical problem that we cannot solve by one man, it goes to a multidisciplinary tumor board, and then the patient gets the best solution for his disease.
Well, and especially your optimistic approach will help with it. Is if one treatment hasn't helped, so we will try another one.
Yes,
Uh,
exactly.
so, well, it is well known, and unfortunately, that cancer has no age, and both adults and children can suffer from this disease. So, do you treat both adults and children? And if there is any difference in the treatment approach?
Well, I treat adults from 18 years old and up. In Israel, the oncologist is is licensed to treat adults, young adults or adults. The children are treated by a pediatric oncologist, who is basically a pediatrician. He's not an oncologist from the beginning. He is in Israel there is a subspecialty of pediatric oncology, and since I'm not a pediatrician, I cannot treat children. But since I am an oncologist in certain fields like sarcoma, I can have the children for consultation, and then I invite the pediatric oncologist to sit with me at the same time. If the consultation is by Zoom or physically, he comes to this office and we see the patients together at the same time. So I give my insight and he gives his insight. And if there is a decision to treat a young child with chemotherapy, so the child goes to his department. But the first meeting is together with me and the pediatric oncologist.
I see. So basically, despite the fact that you don't treat children directly, you can definitely help pediatric oncologist with making decision and with finding the best treatment for the youngest patients. Okay, so if we talk about such mm, serious diagnosis as bone sarcomas, yes, so that maybe need some surgeries. So what surgery types do you use for such type of disease for bone sarcomas?
Okay, bone sarcoma is a disease that is treated by chemotherapy and by surgery. Chemotherapy usually first to try to get tumor control, to try to kill the tumor and to eradicate micrometastases in the bloodstream. Then after 2 or 3 cycles of chemo, we go for surgery. Surgery is done by a orthopedic oncologist. It is usually resection and prosthesis implanting. In some other cases, if there is failure of the chemotherapy, we go for a amputation surgery. This is also a possibility. In most of the cases, we do limb sparing surgery. It means that we, we replace the diseased bone with a new graft or an implant, and there is no amputation surgery. And then after the surgery, there is again postoperative chemotherapy. There is no radiation therapy for bone tumors, usually. Only if the tumors are located in, let's say, the head and neck, in the head. If there is, for example, a bone sarcoma of the maxillary sinus or the maxilla in the face, so the margin of resection cannot be wide because it is the face. We give chemo, we give surgery, and finally we give radiation therapy to try to improve the local control. But in other cases, or maybe in the sarcoma of the spine, also it goes for chemo, surgery, and radiation therapy. But in other cases of long bone, pelvis, we go for a chemo and surgery.
So basically, if
Drugs,
chemo works at first, so you're able to preserve the limb of the patient
yes,
and then
the
to do amputation.
yes, and this is the aim, and the success rate is very high, 95%. There is an option for limb sparing.
That's really impressive, really impressive. So, what about the patients who have the fourth cancer stage? So, should those patients come to Israel or stay at home? What can you advise them?
But it depends what do you want to do. The patient has to decide what, what, what he wants. If he wants to stay at home and let the cancer kill him, we can stay at home. But I think there is a chance for getting control of the disease also in metastatic sarcoma and in a metastatic Ewing sarcoma. If there is a lack and the disease is chemo responsive, there is a chance for cure. Also for osteosarcoma, but these are rare cases. I have several patients with metastatic Ewing and metastatic osteosarcoma from the beginning that they are cured and they live now for more than 15 years without disease. So never give up. This is the motto. Never give up.
It sounds really optimistic, really
Yeah.
optimistic. So, what is your success rate in treating sarcomas?
success rate is, I can show it as a success rate by the number of patients that we have in the follow-up clinic. If the sarcoma was fatal, like pancreatic cancer, so in pancreatic cancer, the survival is 1 year if the disease is metastatic, or localized, it is 3 years, 4 years. The cure rate is low. In sarcoma, the cure rate is high. And I have in the outpatient clinic, in the follow-up, more than 3,000 patients, and I don't have enough time to see them all for follow-up because there are so many patients with which were cured for the sarcoma. Even if they started with a localized disease, they developed metastasis, they were treated for the metastasis, they were cured. So I cannot tell you the rate of success, but the success is high, and it is it affects the time that I don't have for seeing all of them, let's say in 1 month.
I see, but it must be also because like new patients come to you for the treatment, yes, for their need. And how many cancer patients come to you every year?
Well, many, many, and I think I see about 50 patients per week. And then you may calculate how many weeks in 1 year minus vacations and the conferences. It is a huge number.
If the patient decides to come to Israel for his treatment, is there anything that he must know before coming?
Well, you must know that first we have to collect the information, and this takes time. He has to come, to stay till we finish the, the information collection. It is impossible to come and to dictate timetable of, let's say I have 5 days, you have to finish everything by 5 days. Impossible. Even for Israeli guys, impossible. We have to get our time to learn the disease and to get all the information. Then we come out with a plan. This is first. Second, for, let's say, standard of care treatment, the patient can come and we will get the treatment. And what we have also is the supportive treatment after, let's say, the chemotherapy. And this support is very important to the success of the chemotherapy. Uh, it is easy to administer chemotherapy and let the patient go home. And then when he has or she has the toxicity, I'm not there to help him. If a patient comes for treatment, he should be ready to stay for at least 2 cycles and then to see how to support him after the chemotherapy. Also, the patient has to bring with him all the documents, everything, all the papers, all the results, all the CT, the PET CT, all the tissue samples, everything. Because otherwise we will have to start from the beginning. Also, the patient has to come with an optimistic mood. Yes, because we have many ways of approaching the disease. but we have to get the time to tailor the disease, the treatment according to the patient. And this is what the patient has to know.
Maybe you can tell us any success stories about patients diagnosed with sarcoma or other cancer types.
Every patient is his, let's say, successful story by himself. And well, I don't recall of miracles, but the fact that we have so many patients at the sarcoma center means that they keep them alive for a long, long time, even with recurrent disease, metastatic disease. Yes, and the fact that we have such a big follow-up clinic means that something good is happening.
From the very beginning, you mentioned that one of the most important things in successful treatment of any type of cancer is early cancer detection. So maybe you could give us some tips for this early cancer detection, or what are the specific cancer and sarcoma symptoms a person should have additional tests?
Okay, if there is a lump or a mass growing in the body, don't assume that it is just a lipoma, and don't let the general surgeon to take it out without a biopsy or without a CT or MRI. If there is a lump or a mass growing in the thigh, in the back, in the abdomen, stop everything and immediately come to Israel to the sarcoma center. There is no screening for sarcoma because it is a rare disease, but there is some screening programs for lung cancer, heavy smoker with cough, heavy smoker with more than 20 pack years should have a CT. This is important. Not patient, people has to do women mammography, GYN examination, colonoscopy, gastroscopy. There are several uh, tests that people can do in order to detect the the cancer. And if there is a cancer family or a family history of cancer, there is a new blood test that can detect oncogenes in the blood that are responsible for the development of cancer. And this can be done in Israel by special companies. And also, if we're talking about tests, blood tests, there is a new approach to try to detect uh, tumor DNA or fragments of DNA in the bloodstream after surgery in order to decide whether to give postoperative treatment or not. This is a very new approach in oncology, and it can be done also in Israel. And patients should know this. It is a developing field. It is not a standard of care for all cancers, but it is a new approach, and it can be done on an individual basis.
Thank you so much. Thank you so much for sharing that with us, with Bookimed patients.
Thank you very much.